Okay, so actually, if all the presenters from this morning could come up and take your seats here, we're going to open the floor to questions about anything that you saw this morning. So the data, how the pilots work, some of the history, any of our resources. If you do have a question, we have microphones at the end of this aisle. So if you could just come down and speak into those, that would be great.
Impressive that you can extract that much. It's something you've been closed, I think.
Hi, Randy.
Randy Pito, Wellesley, Massachusetts. Can I continue with Dr. Mello's data? Because there are some really provocative things there for me. So I have two comments. One, if I read the data correctly, there were 96 cases where the standard of care was met, but still there was an apology during the resolution conversation. Did I get that right?
Yes, but it probably was not an apology of responsibility. That would have been an apology of sympathy or empathy. I am sorry this happened to you.
Okay.
And that's part of our protocol.
Okay, so the second one is even more intriguing to me because I think it's where our Achilles heel is in terms of this whole process. I think, if I saw it correctly, 16 of the 58 cases where you had standard care violations did not, 16 of 58 did have description of systems improvement. Mm-hmm. So that is a big bucket of cases where we've got a standard care violation and no one's talking about standard care. And I know that's very difficult.
No, and no one's talking about safety improvement, you mean?
Right.
Yes.
Yes. So the question is why?
Systems improvement.
Why is it not higher?
Yeah.
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 Yeah. So again, I'm going to invite Suzanne and Melinda in here, but my guess, just based on doing studies of this kind, is that there's not always a system fix that you can identify. Sometimes it's a simple lapse, or sometimes it's complicated enough that there should be a systems fix, but it's not a simple one that has been identified.
Yeah,
But
I would
let
agree.
me ask Melinda.
Yeah, I would agree with that. I think that's exactly right.
Paul?
Go ahead.
Hugh Kaplan, Mass Medical. Just had a quick question. Pre-litigation notice. I haven't heard that very often. Well, could you define that for us?
So part of the legislation, and you can pick up the entire legislation on the website that we passed as part of 224, was that instead of getting a notice that you're being sued, there would be a notice of intent, and that you would have a 6-month notice during which time to go through this. And this is for every physician in the state, not just physicians involved in this. And again, as we've discussed before, physicians who are in small groups or not formally involved with an institution, the hope is that the insurers will pick up and assist physicians through this process if it's an appropriate time to recognize that the care was suboptimal and that there ought to be an offer of compensation to the patient.
Paula?
Really impressive work, and thanks for the thorough sharing of lessons learned to date. Can you mention that there had been some changes in the patient operations within patient safety or the risk management processes to follow the care algorithm and follow up on these cases? And I wonder if there's more that you could say about what those have been.
Yeah, and Pat might want to comment as well. Pat Folcarelli is our Director of Patient Safety at BIDMC. But they are using the language of these algorithms, which is new, and so there's a different process for as part of intake, as part of classification. They are the ones that are prompting the clinicians earlier about, was there a conversation? How should we be thinking about this case? Have we met the criteria? So the way they approach cases, there's been some nuance to how it's changed, and then there's a tangible change in how the information is recorded in order to be consistent with the care program. Is there anything else you'd add?
The only thing that I would add is the department that even from here. In a department that includes patient safety and risk management staff as well as patient relations staff, some of the operational changes were just basic things like tracking who all these patients are and in what part of the process are they living, and developing better infrastructure at weekly meetings to know what are all the moving parts of this program and where are the people actually in the process. And for a patient who has either alleged harm, who has experienced actual harm, are we sure that we have a patient relations contact for that person? So for every single patient or family that's involved in the process, are we sure that we're having ongoing communication with them? And are we sure who is the right person to be communicating with them? And is that happening consistently? If it's a case that's with the insurer, is the main contact the insurer, who for us is not part of the medical center but is part of CRICO? Or does the main contact for the patient and family continue to be the patient relations staff at the hospital? So these seem like they're simple things, but they're non-trivial matters when it comes to the communication with the patient and the family. And also making sure that that communication is actually happening and not letting people fall through the cracks. So a lot of patients and families at various points, as Michelle described, so I think it really, from an operational side, we had to really think about what's the right structure that we have. Do we have the right structure? And what would we add or change to make sure that the patients and families feel adequately supported? So I think that that's what Ken was referring to. The other thing I'll add, as long as I'm standing, because I don't like standing up here, is that the other thing I think that this is, Ken alluded to this in terms of the change in the conversation at the medical center, but the other thing that I think has happened is you think about even the level of conversation at our patient care assessment committee, or at committees where we're reviewing cases, instead of people now being so focused on the facts of what happened with the patient, the conversation is shifted subtly over time, but is shifting more to the place of how did the patient and family react to the conversation? What was the conversation with the patient and the family, and less about the facts of the root cause analysis. I think that's a very healthy shift for the organization. And that's where you start to realize we're really good about gathering the facts about the event, but not necessarily using the same rigor to gathering the facts about the communication with the patient and the family. So.
Maureen, go ahead.
Hi, Maureen Connor. We all recognize that there are some gray areas around what cases need to move forward for these essential communications to occur. And I'm just wondering, have you ever considered engaging your patient and family advisors in helping to make these determinations? And then secondly, have you ever considered having patient and family advisors or patients and families at the sharp end of these errors participate in the root cause analysis?
I can comment. We started about a year ago with our Patient Family Advisory Council and actually inviting them to sit in the root cause analysis for some significant cases. And that's been very powerful. The presence of one of our advisors just in the room changes the tone of the conversation and really focuses on the patient and on the communication. So that's been very early in the process, but it's something with our Patient Family Advisory Council, which has been very robust in our health system, to invite them there, and we really want to continue that process.
Yeah, and similarly, I'd say we're early in that phase of making those same changes, but at our highest level of discussion of root cause analysis in our institution, which involves chiefs and board members, CEO, et cetera, we have instituted having patients at that session as well. So, so there will be opportunity for comment at that level as well for patients.
Hi, Lisa Stone from the Betsy Lehman Center. Thank you very much for this wonderful presentation. I'm interested in the lack of data around trainees, and I'm wondering if that's because that responsibility falls to the attending physician, and if that's the case, are there internal systems to capture that information? Thank you.
So I would say that most of it actually probably is that the attending is overseeing that care. So when we put the data in, it says who is most responsible for this, so that's why we default to that. But we definitely do track what residents are actually involved in these adverse events, and we present to them about communication and things like that. So they are definitely involved, but I think that's why the data reflects that.
And they're involved, I would imagine, with any kind of support services that are then provided to the attending who took responsibility for that.
Yes,
event.
exactly. So we actually have a peer support network, and there are attendings that support attendings and residents that support residents.
Thank you.
Dr. Dunlap.
Hi, Ron Dunlap, Medical Society. So I have a question about the conflict between administration. So, for instance, we have a catheterization lab, and we might have a situation where we have 2 heart attacks at the same time, and we do emergency angioplasty. So we'll have nursing administration requirements for the number of staff that we have before we can start a procedure, and then we have the urgent need to meet the standard of care for getting this angioplasty done within a certain period of time. And so we've run into situations where we run into this conflict in policy where what's best for the patients and the strict interpretation of, for instance, nursing policy is not administered. So we've looked at this in terms of our system and trying to integrate the 2 administrations, both medicine, cardiology, and nursing, so that we can come up with a best case situation of how we handle that kind of situation. Otherwise, we could actually end up with a major complication because one patient waits 4 hours before they get their angioplasty, which is obviously not the standard of care. So that's one issue of how we have 2 different systems reporting on something and from different perspectives, when I think before they do that, they should discuss this together and integrate their review of the situation and make sure that they've looked at all the system situations and factors before they go on and bring it to a higher level. But the other question is, just in talking to my colleagues, so many of them are really not educated on this process. So the question is, how do we reach enough people? How do we change that culture? Because we really have to educate people. They don't really know what this is, and they're afraid, and they're therefore afraid to speak out.
I'll speak on the second one. You guys speak on the first one.
I was going to say the same thing to you.
Which is really prevention. I mean, he's really talking about how do we, when we know we've got potential critical situations that are likely to lead to an adverse outcome, how do you work within your institution with limited resources to try and accommodate the best needs of major patients?
I guess my comment to the first statement is, I agree. I mean, it's a complicated world, and I think there are lots of situations where you have a conflict between what's the policy and what's the best thing to do about the situation in front of you, and clinicians, nurses, physicians get caught in the crosshairs, I think, with actually some frequency, and we haven't had really adequate ways of addressing that. I think it's a great area to spend more time on. I mean, I'm sitting here thinking of situations we've had where we have had nurses have to choose between respecting privacy and preventing a fall, or respecting a patient's wishes and preventing an adverse event. And this is what makes healthcare so complicated. So I think trying to create as much consistency as possible between policy and what has to happen is kind of an ongoing work of both clinicians and administration, and I think it involves refining processes and policies as you come across these situations. But I think they're going to continue to crop up.
I would say relative
Can you do any better than that?
Pretty good. The only thing I would add is I think this is the place where we talk a lot about redesign of our work, and it's a place really in terms of our process improvement work where we actually in terms of prevention, bringing everybody together to focus in on redesigning a practice, redesigning the standards of care so that it is a single process, and it's really breaking down those silos from nursing to administration to physicians that happens in that redesign process. So for a lot of the lean work, for instance, really tries to focus on that very process.
The second question was related to how do you educate physicians, and I think, Ron, as you know, we've had 2 articles in the vital signs that go out to 24,000 physicians plus. We've had multiple articles in electronic media. We've engaged at Mass Hospital in trying to educate people. I have gone out and spoken to 8 specialty societies, the orthopedists last week, and we're trying, and on our website is you can just click and request a speaker. So we're trying to make resources available, and we have spoken at multiple hospitals. I think all of us have spoken at multiple hospitals that are not currently pilots. And in the audience today, we have several hospitals represented, when I looked at the list, who are sort of considering, is this a model we want to adopt at our institution? So it is gaining traction, and I think there's increased awareness. But and we mentioned social media has been another avenue, but we're that's obviously why, in part, why we're here today. But we're trying to use all of the outreach mechanisms we can, and if others have additional ideas of how we can get the word out, we're very receptive.
And I think the tipping point will be when it's not those of us who are committed and doing this work as sort of our jobs, but when it's a conversation in the field, in departments, and they're talking about this as the way the work occurs. I mean, I think that's when it will really disseminate. I mean, right now, it's been a bit of trench warfare. You know, I've walked to every single one of the departments in my institution. I'm sure Evan's done the same, just trying to get the word out. But I don't think that will ever be enough until you can start getting people actually starting to talk about it as this is how we do our work.
This is the culture. And the institutions that have had this in place for some time are the ones who are talking about culture change, and even a bending of the cost curve as a result of the cultural change and the fear. And Rick had some surveys of physicians relative to their satisfaction with and awareness of the concept, and had overwhelming support. But it takes time. We're talking major culture change.
Lori Riley from UMass. And if I may add, our CMO recently had a speaker come in for our medical staff dinner discussing these issues, disclosure apology, and how to support one another. And it was very well received. And as a risk manager, I'm getting a lot of calls, which is awesome. But my question is regarding service recovery. I find myself kind of in the crosshairs sometimes. We are required, when it's an SRA, service reportable event, to cover on a hospital side, but then I also run into compliance issues as well. And I'm wondering how people deal with the service recovery, whether it's really the hospital side or whether it's coming from our insurance companies.
Sure. So I can address that. So if we were to waive a bill as service recovery, something small, and we would report that to the insurers as well, because of the compliance issues, like you're saying. If there are other kinds of service recovery, though, so we might sometimes, pay for parking or cafeteria meal or something like that. So those would all be included in service recovery. So those would be something that the hospital would do, not the insurer. Does that answer your question?
Sometimes it can add up to be a lot of money, and then you run into compliance issues.
Mm-hmm.
They want the hospital to pay for everything for a really long period of time.
Right.
Hi, Susan Tarrant, also from UMass. Has your research involved self-insured hospitals as well as commercially insured hospitals? And if so, if you have that range,
Really?
do you see the propensity to reach out more or less from either of those two entities? Reach out to a patient who's been harmed, yeah. For instance, the Nagashi story, in the old days, we would have waited. He didn't call, he didn't write. We would have waited and seen if he made an approach to the medical center. Now, in your case, you reached out to him and did what was the right thing. But just interested in those two.
Well, so all of the hospitals to date have been self-insured through captives, all of the 6 pilots, and that's why we're adding Sturdy. So we really don't have any data to see if there's any kind of difference related to that, and we hope and don't expect there necessarily to be. And again, in incorporating Sturdy Hospital, they have the support of Coveris, who's their insurer. In fact, it turned out that Coveris suggested that this is a hospital ready to move in this area as far as its risk management infrastructure, et cetera.
I can speak a little bit to that as well, because I've been involved in other projects where we have had different insurance arrangements. And I've not worked with a purely commercial insured hospital, but I have worked with a set of hospitals who had they had some influence over their insurance entity, but it was not a wholly owned captive. So in my experience, it doesn't, as a matter of principle, it doesn't matter. What matters is whether the insurance entity is on board, not what their organizational form is.
Okay.
As a practical matter, when you don't fully own and control your insurer, and when there's a physical separation, so your insurance representative is not on site, and there's not as strong a relationship, it can be, there are more, what economists might characterize as transaction costs involved, right? It takes longer, more phone calls and so forth. That can be an issue. The other issue is that insurance companies may impose procedural requirements that the hospitals would rather not have. For example, one of our insurers would not talk to a patient about compensation until they had retained an attorney. And the hospital didn't feel that was necessarily the way they would have gone if they had had it their way.
Thank you.
We're going to take 2 more questions and then break.
Hi, Dr. Patricia Falco with the Massachusetts Medical Society. I'm the chair of the Committee on Maternal and Perinatal Welfare, and we're very grateful to Dr. Woodward, who has engaged with us to try to help bring this information to the Massachusetts section of the American Congress of OBGYN. So the committee within MMS and this larger statewide section of OBGYNs. And we got a lot of pushback from folks on the committee and from the Mass ACOG State Advisory Committee. They want specific data about OBGYN results from projects that may be pilot projects here within Massachusetts. They don't want to hear about California and Michigan. They don't want to hear about anything except the climate that exists in the local area where they are, and they want to see those premiums come down. They want to see patients happier. They want to see doctors included in these negotiations well, and not have all these things going on back, kind of behind their back, where they don't know what's going on. They feel an insurance company may be settling something for them. They end up with things located on their national data bank, and everybody's very unhappy. Now, I know OBGYN is a significant portion of the dollar of all of these, whether it gets pushed into a defensive mode or even when 95% of the claims do not end up in a payout in a jury trial, there's still significant costs all around. So in terms of educating physicians, we've tried to connect Dr. Woodward, and the pushback we get from these 2 groups, the committee at MMS and the Mass ACOG section, are give us local data and don't talk to us blah, blah, blah in one ear and out the other. And the second thing is just that I've helped to connect Dr. Woodward with our interspecialty committee here at Massachusetts Medical Society, in which I serve as a state member at large. So that has 26 specialties, and they are more interested to have this general understanding so they can begin the dialogues with their individual specialty societies. So there are 26 specialty society presidents and state members at large on that. So thank you very much for the work that you're doing. We're very excited about, but we're not ready to bring Dr. Woodward to us until he can give us this local data. Thank you.
Well, this is what you hear all the time. What works in Michigan, what works at Stanford can't possibly work in Massachusetts. Jeff Driver will tell you their program's been in place for 6 years now, and they haven't had a single OB case go to court. So, and I think University of Michigan I actually talked to was sitting at a meeting with one of their heads of OB who said to me, we now teach our residents in OB to practice safe medicine, not defensive medicine, and it's been a radical cultural change, and we're very pleased with the program. How soon we're going to have enough data to please local OBGYNs, I have no clue. But it's the concept that one specialty wouldn't want to hear about a model that's working across the country and clearly is showing no adverse outcomes in Massachusetts is sort of an interesting phenomenon.
I hear this sort of thing a lot, being the designated data nerd on any panel of this kind. And, one thing that I've really come to believe is that for someone who doesn't believe it's the right thing to do, that no amount of data about the business case will ever be sufficient. If you believe it's the right thing to do, then you're willing to take a leap of faith based on a plausible case that there's a business reason to do it as well. But for those who are overwhelmed by fear and are just unwilling to get past that, you will never be able to satisfy them with the kind of data that we can provide. I think what tends to be more persuasive is hearing from clinical leaders. I believe strongly that we have to do this for our patients and to support our providers, and I believe in my heart it won't kill us financially. But come with me and let's try it. And the great thing about a private law experiment like this, it's not a public law reform. If it's not working for your organization, you fix it or stop it. It's not a sticky reform. So, and I know Rick agrees with me on this. If it's the right kind of organization to succeed in this approach, they'll be willing to take that small leap of faith with the data that exists.
Last question.
Thank you for the excellent presentation on the work that's going on. I have two questions. One of them is perhaps a nerdy question. I was just wondering what the resource utilization, human and others, in terms of setting up and running a program, and just simply giving numbers is not going to be meaningful. I'm sure you people know that a lot more. As a quotient, what is the denominator in terms of number of patients, number of potential cases, or whatever? That's one question. Not to undermine the effort, I just wanted to see what it is. And the other question I have is more from the patient perspective, or the patient choice issue. In many cases, and I'm an orthopedic surgeon, so there is a lot of choice in that, patients do make choices or should be able to make choice, and we want them to be more engaged. And there is a parallel between that and the risk for various things. You choose one course at a certain thing, anticoagulation or not, or what to do. So I'm just wondering, is that somewhere fitting into the equation? Is that possible to even include that in the way in which you are analyzing the meeting standard of care? There may be standards of care in terms of what the patient. So I was just wondering if there's something there is a flexibility. The classic word used is patient adherence or compliance, but more than that, the patient has the right to choose what they want to do. Thank you.
Yeah, well, I mean, maybe I'll let Melinda answer the second question, but I think the standard of care challenges that are faced in this program are no different than the status quo. It's the same determination. They face the same factors around variable resources, more than one acceptable practice style, the sort of respectable minority practice style, for example. So I think those challenges are always going to be there, and this program doesn't really shift anything about them except how quickly people get to dealing with them. On the first question, again, I'd be interested in Melinda's view, but the figure that has consistently come out of the other studies that I've done is that this program works best when you have one FTE full-time devoted to it. Now, and there have been hospitals that have been successful, and Rick's the prime example, Rick Boothman at Michigan, of this, that have not really added to their staff and have done wonderfully. But for those who don't have someone who works 27 hours a day on this program and is a true believer, I think hiring one program manager full-time significantly improves your prospects of success.
Yeah, and I would agree. I mean, the existing structure of patient safety and risk managers and patient relations staff, they have a lot of volume, a lot of other work that comes in, a lot of cases that come in. We have 3,000 complaints every year that come in just through the line. So there's a lot of other work being done, and they all believe in this and they want to do this, but there needs to be somebody that can say, this is a care case, this is how we need to do this, is this happening, because there's just a lot of other work that goes on. So I think that, as Michelle said, it's really helpful to have somebody that's just thinking about this.
All right.
So, okay.
Thank you.
That's
We're,
right. Okay,
so we're about 15 minutes
So,
off.
yeah.
I think we'll do a 10-minute break.
Yeah.
And then we'll begin with the next part of the
Okay, so we'll start again
part
around
of the show.
11:10.
Thank you.
Thanks.